I think we should start. My name is Kristian Reich. I'm a dermatologist working in Hamburg, Germany, and it's an absolute pleasure and delight for me to do the symposium with you and of course with my esteemed colleagues, Professor Richard Warren from Manchester, the UK, and Professor Brian Kirby from Dublin, Ireland. We have been a good team in the last years, and I'm sure we're not going to divorce now in this symposium here. This morning was the psoriasis-free communication session. Were you there? There was like 70 seats in the room, and there were like 400 people waiting outside the room to get in. Even I, as a speaker, I couldn't get in, right? I insisted. I had to go through a fight. Now, the good thing is that this signals to me that there still is a big interest in psoriasis. What actually also happened there, that many colleagues approached me after the session and said, I am lost now, right? We have etanercept and infliximab and adalimumab and ustekinumab and secukinumab and tildrakizumab, guselkumab, risankizumab. What should I use? What should I use? I'm lost in the jungle, and I do not understand why 2-3 antibodies that have the same target should be different. So if you seek answers to these questions, you are at the right place. Because this is exactly what we will discuss with a focus on the most recent targeted therapy class, the IL-23 inhibitors. And when we say IL-23 inhibitors, we really mean IL-23 P19 inhibitors. And you will again hear from me in a second how they can be distinguished from a drug like ustekinumab that also blocks interleukin-23. Now, this is the disclaimer, sponsored by Janssen, but we will give you our authentic view of the data. There are a number of learning objectives. I will not go through them. I would be very happy if you walk home and say, A, dermatology is fantastic. B, I understand how to treat psoriasis, and specifically, I understand the value of the class of the 23 inhibitors. This is the program. After my short introduction, I will give you a little bit of background on the pathophysiology. What is the role of TNF, 1723? Where do we think they play a role in the psoriasis disease cascade? With the intention that you learn from this, what you then hear from Richard Warren, which is, what do they do in the clinic, right? And Richard, I saw his slides yesterday. He will give you a fantastic overview about the available clinical trial data for the different 23 inhibitors. And then last but definitely not least, Brian Kirby will explain to you, yeah, all fine, but this is clinical trial data. What does it mean for my daily practice? What with the different disease domains? What even with comorbidity? So you will get the full package. Save your questions to the end. You have all received this. Have you received this? Where have you are? It's not a present, right? It looks like an iPhone, but it's an I without the phone. So if you press the home button, you can look at our pictures, but that's not the main intention. The main intention is that there is a button called Q&A. And if you press this, you can type in a question. And if you want to send this anonymously, you can press the button anonymous, and then this question, I will see this question here on this little iPad, and we can discuss in the end. But you are also invited to go to the microphone and ask your question. So we will have a nice, crisp discussion at the end. Are there any open and remaining questions? We heard wonderful iPhone rings this morning, right? But I think it's probably nicer if you turn your phones on mute and we can really focus on psoriasis and its treatment. The meeting app I already explained, so you can look at this. It's really very simple, even I can do this. So without further ado, allow me to start with a walk through the jungle. I actually don't know where this is, but this is the jungle. And I remember some years ago, we were actually talking about psoriasis like the cytokine soup, right? And IL-8 and interferon and TNF and IL-12, IL-23. I think there is now at least a path through the jungle. Some of this is hypothesis and model, but let me walk you through this. These are the classes we now have. And sometimes I get this question, Kristian, if you should go to an island in the ocean and you should treat psoriasis patients there, you can only take 3 drugs. Which one would you pick? Actually, our answer, I would probably still pick an anti-TNF, probably adalimumab or certolizumab. I would definitely pick a 17 inhibitor, and I would pick a 23 inhibitor. So there is, to say this already at the beginning, there is, I think, no one size fits all. Right? And this is why we need to have the symposium and understand a little bit better what is the specific role. This is psoriasis. If you take a biopsy, you see here normal skin on the left side, you see psoriasis, you see the dramatic changes in the epidermis, you see the hyperkeratosis, the parakeratosis, the thickening of the epidermis, the acanthosis, the elongation of the rete ridges, and you see all these cells that infiltrate here. And it has been a big learning of the last years that we think the inflammation is probably the hen, and that these exaggerated repair function that we see for the keratinocytes are a consequence of the inflammatory process that is going on. I will also show you a little bit later that I think the keratinocyte comes back, strikes back. And the keratinocyte, to already say this, more and more is perceived as an interesting source of cytokines that signal back on what's happening with the immune system in our skin. Most of these cells here are T cells and neutrophils. Let's not forget that psoriasis is the disease with neutrophils, but the T cells and the memory T cells and all these different T cell subsets I think are perceived by many as the key inflammatory cell that plays a role in psoriasis. Now you probably are aware that T cells on their own, they don't do anything. And I want to make it clear, and I want you to take home 3 levels of contact that T cells have with a cell that is activating T cells, which is the antigen-presenting cell. In the skin, because it's an external surface, we have a type of antigen-presenting cell that is 100 times more potent than a macrophage to mount a primary immune response. And the name of this antigen-presenting cell, of course, is dendritic cell. And as you know, in the epidermis, we have a special dendritic cell that is called Langerhans cell. Now, the crosstalk between this dendritic cell and the T cell, what we call the immunologic synapse, that has been an area of intensive research and interest over the past years. And I would go so far to say the majority of targeted therapies that influence immunology either inhibit inflammatory responses or, in the case of cancer, activate immune responses. They have something to do with, they manipulate this immunologic synapse. They manipulate this crosstalk between dendritic cells and T cells. So here's a staining. This is a staining for dendritic cells. This is a staining for T cells. You see that these cells in psoriasis actually co-localize. They talk to each other. And I borrow this slide from Jim Kruger. And I tell you why I'm fascinated by his view, his current view of the pathophysiology of psoriasis. You see here this crosstalk, right? Dendritic cells, they talk to T cells. They present an antigen. That's interaction number 1. They have co-stimulatory molecules activating and inhibiting. That's interaction number 2. And then they release a cytokine during this contact, and this educational cytokine is telling the responding T cells what to do, to become a Th1 cell or Th17 cell. So there are 3 levels of interaction. And here you see the educational cytokine, interleukin 23. That is the, let's say, the current paradigm that this is one of the most important mechanisms in psoriasis pathophysiology. As a consequence of this, the activated T cells release cytokines like IL-17. And this is where the name Th17 comes from T cells that have IL-17 as their signature cytokine. And I will show you in a minute again that one main activity of 17 psoriasis is to activate the keratinocyte. But then, and this is what I love about this slide, you not only have this feed forward the response, the immune system is doing something with the epidermis, but you also have a feed backward response. And I tend to think that I would be a young researcher today. I would probably be very interested in epidermal immunopathology. See this growing list of cytokines that activated keratinocytes make? Interleukin 19, 36, this may play a role in pustular psoriasis. Interleukin 8, one of our main chemoattractive factors for neutrophils. There is a growing number of cytokines that activated keratinocytes release and that signal back on the immune system. So we not only have a simple upstream, downstream, we have actually a circle. We have a feed forward response and we have a feed backward response. Actually, we have a lot of flickering here on the, I hope you don't get sick. Right? So, all right, can we change this? You're working on it? Okay, thank you. I can tell you that the 23 inhibitors work a lot better than the projector. Yeah? That is my first conclusion here. Now, the world of IL-17 is actually more complicated. It is a family of cytokines. And what you see here in the upper panel is normal skin, non-lesional skin, active plaque. Normal skin, non-lesional skin, active plaque. So the orange bar is showing to you what's happening in an active psoriatic plaque. You see that in addition to IL-17A, at least IL-17F and C are also significantly overexpressed in psoriasis. It is my feeling that we will hear and know and talk a lot more about different IL-17 family members in the future. Just a little bit of insight from recently published work. This is a cell culture model. So you take human keratinocytes and you activate them with IL-17A or F, with or without TNF. And your readout is the production of a human antimicrobial peptide called human beta-defensin 2. And what you basically see here, that only if keratinocytes are primed by TNF, then IL-17A and more than IL-17F activates keratinocytes, measured here by the release of human beta-defensin 2. And now you understand why TNF inhibitors also have their say in this, right? Keratinocytes need to be primed by TNF. That's the yellow curve, and then the addition of IL-17A, that brings about the maximum activation of keratinocytes. Why is this important? Because with the therapies that we have, we can actually dissect the pathways. Drugs like secukinumab and ixekizumab are IL-17A inhibitors. And because of that, they will block the homo and the heterodimer containing IL-17A. You see that these A and F, they work as dimers and they signal through the same receptor. And actually this blue receptor chain that is also part of the receptor of other IL-17 family members, this is what brodalumab blocks. And in the future, and you hear more about this during this meeting, we will get a third type of IL-17 inhibitor, bimekizumab, that in addition to A also blocks F. Now, isn't this interesting? This will allow us to understand more specifically, is there a role for the IL-17F homodimer? My impression is, and careful read this slide, right of this dotted line, you see phase 2 data, okay? No label yet. This is psoriatic arthritis, and these are the ACR 20, 50, 17 responses. And just by looking at this, you can see that the responses to bimekizumab, ACR 20, 50, 70, in phase 2, limited study results, need to be validated, replicated, but the results look fascinating. So we begin to understand that maybe even in different disease domains, different IL-17 family members play their part. And maybe this indicates that in arthritis, there is a specific role for IL-17F. I'm also fascinated by this data because I always ask myself, why do we often see the skin manifesting before the joints? And you are probably aware that rank ligand is a cytokine that activates osteoclast function, so cells that eat the bone. If you have an advanced osteoporosis, you can get a treatment with a rank ligand inhibitor, denosumab, and you can decrease osteoclast function, you can increase bone density. Are you aware that keratinocytes stimulated with IL-17 and TNF can make rank ligand? The skin can make the cytokine that turns on osteoclast function, and that is probably responsible for the erosive component of psoriatic arthritis. Fascinating data. One thing that I'm not going to discuss, but just mention to you, the key question, okay, Kristian, yeah, but why do we in psoriasis have an overexpression of TNF and 23 and 17? The probably correct answer is because there are genetic factors in these patients that lead to an abnormal, for example, exaggerated cytokine response. And it's interesting to see that the genetic factors that we have found to be associated with psoriasis, they are related to the pathways I just discussed with you. So there are genetic factors that lead to an overexpression of TNF at 23 and 17, and we find these genetic factors associated with psoriasis. So genes do not lie. Yeah? And cytokines that have been targeted and that has not led to an improvement of psoriasis, like IL-8, you don't see an IL-8 association here. So that's very interesting. In the end, we will have to discuss whether these different target therapies treat all the different disease domains in the same way, and Professor Kirby will discuss this with you. You probably already have a little bit of a feeling that when it comes to nails, for example, or arthritis, for example, maybe comorbidities, it could be that the different classes lead to different results. My simplified model, sorry, this is really complicated. My simplified model, my simplified model, it won't let me show this. Yeah. So, I'm not showing you the simplified model, I show you the complicated model right away. The point I want to make here is that with 17 inhibitors, you sometimes see candida. You know that you should not treat a patient with a personal history, IBD, with a 17 inhibitor, because in clinical trials, 17 inhibitors have not only not inhibited IBD, but in some patients it got worse. With 23 inhibitors, you do not see candida, and there is evidence that they may work in IBD. And the current model, I use a very careful wording here, the current model, a possible explanation is that 23 significantly turns on what you can call the pathogenic 17 production, but that there is a 23 independent, normal, healthy, physiological 17 production. Now, of course, when we treat patients with psoriasis, we treat patients that have too much 17. We want to normalize this, but maybe in some patients we oversuppress, and this is why we begin to see these problems. We also have to talk about the long-term control. We have a chronic disease, and it may well be that because of the differential role of cytokines in the cascade, targeting some cytokines has a better potential for therapeutic longevity than targeting other cytokines. This is a terrible situation, and I just want to remind you that there are individuals living on this planet that have a genetic defect in the IL-17 pathway. They either cannot make 17F, or they have a mutation in the IL-17 receptor A chain, or they have a mutation in STAT1, which is the signal transducing molecule for IL-17, and this is their phenotype. They don't get TB, they don't get cancer, but they get very severe chronic mucocutaneous candidiasis. So this is the IL-17 now phenotype, and psoriasis is the IL-17 plus phenotype, and this is obviously what we don't want to see. Now, in all fairness, in a recently published overview about the safety of secukinumab across the different indications, if you look at the candida signal, it is very, very small. Right? If you treat 100 patients for 1 year with psoriasis, you see 2 cases of candida. And you have to treat 10,000 patients for 1 year to see some cases with Crohn's disease. But it is clearly, I think we would all agree, a differentiator between 17 inhibitors and 23 inhibitors. It's due to the fact that in addition to the physiological role in the skin, 17 seems to have a dual role in the intestine. On the one hand, it may promote inflammation, but on the other hand, it may also contribute to the intestinal homeostasis and to the epidermal barrier function. Is this relevant? I think it may be, because our patients with psoriasis have an approximately 3-fold increased risk to develop inflammatory bowel disease compared to patients not having psoriasis. Last, but again, Brian Kirby will come back to this, the story of the comorbidities. Just a snapshot, and again, Brian will talk about this in more detail, a snapshot that I find extremely interesting. This is from the study where guselkumab was compared to adalimumab. Double-blind study. And these bars indicate the protective effect on anxiety and depression. And what you see here is that in this study, guselkumab had a higher, if you will, I'm oversimplifying, protective effect on this psychiatric comorbidity. So again, this is something we need to explore. I want to finish with a concept that we are more and more confronted with, and this is the concept of an inflammatory memory. Have you ever asked yourself why, if you bring a patient from here to here with narrowband UVB or from here to here with etanercept, why, if you stop the therapy, the disease comes back? One possible explanation is that the skin may look normal, but it may actually not be normal. And we actually can identify a T-cell population in these lesions that we have been calling resident memory T-cells, and we can describe their phenotype. They carry CD8 and CD49A and CD45RO and CD103, and they make IL-17 and they make IL-22 and they carry the IL-23 receptor. Now, could it be that in some patients, through using targeted therapies like the 23 inhibitors, we can actually extinguish this inflammatory memory? Wouldn't this be fantastic? There will be a talk on Saturday in the late-breaking session where from the comparator trial between guselkumab and secukinumab, we will look at the number of resident memory T cells before and after these therapies. And I have already seen the results, and they are really exciting. So the clinical phenomenon is that if you take the drug away, this is guselkumab, if you take the drug away in responding patients, and you see how response is defined here, you see that in a subgroup of patients, there's a long maintenance of the response beyond what you can explain by pharmacology. So again, the question is, do we see embedded in this subgroup patients where we could go to longer injection intervals? And we actually have been showing that in the patient where the disease does not come back, you cannot find the reoccurrence of an IL-17 response in the peripheral blood. As if in these patients after treatment with guselkumab, this inflammatory memory would have been extinguished. If you ask the question, who are these patients that have a higher likelihood that the response is maintained, there has been a logistic regression, and this is with some accepted, I think expected findings, such as PASI 100, the fire needs to be out, lower weight, but also a finding that I personally find extremely interesting, short disease duration. My patients that come to me, if I ask them how long do you have psoriasis, they say since 15 years. And when you ask them how many months have you been disease-free, they say, what are you talking about? I've never been disease-free. And this may exactly be the reason why the probability that they will ever be disease-free without therapy is extremely low. So maybe if this data is replicated, we really need to change completely our treatment paradigm and move on to an early remission and to prevent the establishment of this inflammatory memory. Just to remind you, the study, there is now a study that will look into this. Don't look at this complicated study design. But what is happening here is that patients will be enrolled, some of them with a short disease duration, less than 2 years. These are patients we have not been enrolling in clinical trials before. They will be treated with guselkumab, and when they have a PASI 100 response at week 28, they will be randomized to either continue on every 8-week dosing or go to every 16 weeks. And if their disease is still controlled after 1 year, the drug will be stopped. And we will take biopsies, and we'll measure resident memory T cells, and we will look for regulatory T cells. So in a year or 2 years, we may be able to say, look, if you are in this subgroup, in order to keep your disease under control with a drug like guselkumab, you only need 1 or 2 shots per year. And I think this is as good as we can be at this point of time. So IL-17 A and F, to summarize my little overview for you, they seem to be the key activator, probably IL-17 A with a more prominent role. They seem to be the key activators of TNF-primed keratinocytes. It seems to be that IL-23 is kind of a master cytokine in this, activating pathogenic Th17 cells, but probably also playing a role in activating other cells such as neutrophils. There is already evidence for a differential role of 17 versus 23 in different disease domains. We talked a little bit about the role of IL-17 in psoriatic arthritis. Very soon, phase 3 data for guselkumab will be presented, and at least if they replicate the phase 2, we may see that 23 inhibitors also work in psoriatic arthritis, so this is very interesting. And I would hope that by understanding the pathophysiology better, we will understand better why we see the clinical effects that we see. And with this, I would really like to thank you very much for your attention. I would actually, if you have questions, write them down, send them to us, it would be perfect if we could have a little bit of a joint discussion at the end. Right now, I would like to move on. Now, this was the bench, Richard. And the key question here is, can we take this bench knowledge to the bedside? So please, Richard, what is the clinical trial data with the 23 inhibitors?
Thanks very much, Kristian. I'm pleased to say that the screen seems to have settled down as the calm English influence takes over from the rapid German torrent that's been on the stage. And so all is calm as we work through the clinical trial data. So there's my disclosures for you, and I suspect the screen will start misbehaving instantly now. So, as Kristian said, our theories around what is causing psoriasis and the immunopathogenesis of psoriasis has changed a lot over the years. But we have had a number of different therapies become available. We have to be completely honest. Really, in the early days, targeted treatments such as methotrexate, etc., were just pure serendipity. And indeed, even the early biologics, like the TNF inhibitors, were designed to treat other diseases. But the discovery of interleukin-12 as being key to Th1, and more importantly, IL-23 being key to Th17 responses, and the discovery of IL-17 as a pivotal cytokine as well, has really led to the evolution of lots of different treatments that were designed for psoriasis and are now in the clinical environment. And this talk's going to focus on the IL-23s, and here you can see the available IL-23s. We've got guselkumab, tildrakizumab, risankizumab, and there is another 23 at an advanced stage of phase 3 called mirikizumab. So I'm going to take you through some of the clinical trial data for each of the IL-23s, the first one being tildrakizumab. So a bit like Kristian mentioned with the guide study, don't get overwhelmed with the study design here. Tildrakizumab, although it wasn't the first to be licensed, this was the first program for an IL-23 that was put together. And here you can see that tildrakizumab comes in 2 doses that were compared against placebo, and in one study, they were also comparing it against etanercept. The primary endpoint of this study was set at week 12, and we'll discuss how that was probably too early for this particular mechanism of action. And then there was a whole series of re-randomizations that could go on, switching between doses, swapping from placebo, and swapping from non-responders to etanercept. So here's the key thing. The PASI 75 response at the primary endpoint, week 12, you can see on your left-hand side, and then you can see the PASI 90 response on the right-hand side. But we can see that those responses continue to climb, and I think it's fair to say that tildrakizumab hadn't reached its peak efficacy, and sadly, in effect, the trial design wasn't the right trial to showcase how efficacious this drug was. This is then the data from week 28 through to week 148. And again, it's important to be clear that there are re-randomizations going here, so there's only necessarily populations who are responding at a certain level who were being taken forward. But the critical thing is, whether it was the 100 milligram or the 200 milligram dose, the actual retention of a good level of response, PASI 90, was very, very good on tildrakizumab. And for transparency, across the bottom here, you can see the actual numbers of patients over time. You can also see 3 lines, and that refers to the type of analysis that's being done. So you're probably aware something called a non-responder imputation refers to anyone who drops out for whatever reason is counted as a non-responder. If it's an observed population, they only take the denominator as the number of patients getting to that time point. So this was a slightly older study with a number of different variables within it that make interpretation a little harder, but the take-home messages are tildrakizumab was superior to etanercept and had very good retention of response in those who responded. So Kristian mentioned some of the Voyage studies. This is the Voyage 1 study design, much more straightforward than the Tildra designs. And you can see that you were either on guselkumab or placebo, or there was an active comparator, adalimumab. The primary endpoint for this study was week 16, but the comparative assessment against adalimumab went on right out to week 48. Placebo patients switched onto guselkumab at week 16, and then there was a long open-label extension study. This is the primary endpoint, and I think it's important to show that this was a non-responder imputation analysis right out to week 48. And here you can see PASI 90 responses of 73.3% for guselkumab, close to 50% for adalimumab. So a big difference, 20+%. And we can see that over time, that difference gets a little bit bigger. And one of the clinical phenomena you will be aware of with adalimumab is that patients seem to get secondary lack of response, possibly in part due to immunogenicity. And you can see that when a non-responder analysis is done, there is a slight drop-off in efficacy, whereas when we look at guselkumab, the efficacy is maintained going out to week 48. The patient switched across from adalimumab at that time point, and indeed there were excellent retention of response right through to week 156. Now this study, Kristian's shown a little bit of data from this, but just to explain a little bit more about the design. So this is, we're following the guselkumab arm here, and then individuals who at week 28 were a PASI 90 responder could be re-randomized to carry on guselkumab, or they stop treatment. Okay, so they stopped treatment or carried on. And here you can see, if they carried on, there was very good maintenance of PASI 90. Well, we'd expect that from the trial data we've already seen. And I think this graph is probably presented a little unfairly because actually this is 72 weeks out here. So this isn't a dramatic fall off at all. It's quite the reverse. This is actually showing that even if you've stopped guselkumab, the retention of PASI 90 response, for example here, is still 35.8%. So as Kristian was alluding to, there is something very interesting about this mechanism, that in a proportion of patients, even if the treatment is stopped, a very high level of response is maintained. Now these sorts of studies are done because the FDA mandate that, but from a clinical perspective, it's helpful to us because if somebody needs to stop a treatment because they're going for surgery or for whatever reason, we can reassure ourselves that to an extent they will maintain response. And I don't think any of us here would be advocating stopping treatment and going off license in terms of the dosing until we have a much clearer understanding from studies like GUIDE. But I think this is compelling data of which we haven't really seen this level of retention of response with other mechanisms of action. In individuals who did stop the guselkumab and then lost 50% of their PASI response at week 28, they could be retreated. And what you can see here is through the weeks, most of them then regained a PASI 90 response, but not all of them, which is another reason why we wouldn't necessarily advocate stopping treatment or spacing more than the licensed dosing. And then the newest IL-23 to be licensed is called risankizumab. And here you can see the risankizumab study. This is an integrated analysis of two studies, one called Ultima 1, one called Ultima 2. The design was the same. They were compared in this instance against ustekinumab, and then there was a placebo arm that switches across to risankizumab. You can see the PASI 90 responses across these two studies, integrated analysis, 75.1 at week 16. So again, a very high level of response and close to around 30% better in terms of response versus ustekinumab. Another interesting point, I mentioned in the guselkumab adalimumab study, the fall off in adalimumab after the primary endpoint. Now you will often, if you've used ustekinumab, know that patients will come back at week 8 complaining that their disease is starting to creep back and can they have their jab a little bit earlier. And I think you can very clearly see that phenomenon here with this up-down kind of breathing effect in the ustekinumab arm. Whereas if you look at the risankizumab arm, it's much straighter, suggesting that the dosing of the drug is far more appropriate for maintaining a very stable level of response. Risankizumab has also been trialed against adalimumab. The primary endpoint showed that risankizumab was statistically superior. No surprise here, a PASI 90 response of 72.4 at week 16. But a lot of you will be using adalimumab. It's now available as a biosimilar in Europe. So what happens if you are having an incomplete response to adalimumab. And this study, and would switch on to risankizumab, and this study was able to demonstrate that. So the adalimumab group, if they were less than PASI 50, all of them go on to risankizumab. If they were intermediate responders, which is a relatively high bar there, but PASI 50 up to 90, they could stay on adalimumab or they could go on to risankizumab. If they were doing really well on adalimumab, they stayed on it. Here on this graph, you can see the risankizumab group in yellow. That's staying on risankizumab throughout. If you were one of those intermediate responders and switched onto risankizumab versus staying on adalimumab, that's the difference that you can see here, and it's obviously far more favorable to switch therapy. And then finally, like the gazelkumab data where patients had the drug withdrawn, this is a similar concept here. Risankizumab patients who were doing very well at week 28, in this instance, if they had an SPGA of 0 or 1, so that's nearly analogous to PASI 90, it's just a slightly different outcome, but effectively close to clear skin. What happened to them? You could see here that even if you withdraw the drug, but it is presented here as PASI 90, which is why we don't quite have 100% correlation, because SPGA 0 or 1 didn't correlate perfectly with PASI 90. But then if you look at the PASI 90 retention on risankizumab, it's excellent. And then you see if you withdraw the drug, still 50% of patients at 1 year are still achieving a PASI 90, in this instance, having had their last injection at week 16. So again, talking to this story of prolonged response with IL-23 inhibition. So what about patient-reported outcomes? So just a conceptual thing, you may or may not be doing DLQI in your clinics, but DLQI 0 or 1, when Andrew Finlay published about DLQI, he demonstrated that if the score was 0 or 1, the impact on a patient's life was effectively nothing. So that's an aspiration that the patient may want to attain. And here you can see it matters what level of PASI response you achieve because it correlates, not surprisingly, with 0 or 1. If you get a PASI 100 on tildrakizumab, the numbers of patients achieving a DLQI 0 or 1 is a lot higher than PASI 90 to 99, PASI 75 to 89, etc. So this is important. We can now see that the proportion of patients on gazelkumab versus adalimumab achieving a DLQI 0 or 1 at week 16 or week 24 or week 48 is very high. And the results are really great, with about 60% of patients reporting absolutely no impact on their life in perspective of their psoriasis. And around 75% of patients treated with gazelkumab continue to maintain this superb DLQI score of 0 or 1 right out to week 156. Here's some risankizumab data again from the Ultima 1 and 2 studies, and you can see superiority in DLQI 0 or 1 at week 16 and at week 52. The hatched bar there is the patients who've switched across from placebo onto risankizumab. So it's all very well having a great level of efficacy, but what about safety? And again, Kristian has alluded to some of the specific safety issues that may exist with certain approaches, such as IL-17. But how does IL-23 shape up when it comes to safety? Now, when we present safety, unlike presenting it from week 0 to week 16 or week 16 to week 52, what we're really interested in is how many patients have had treatment for how long, and then we put all of that together to get a cumulative safety report, and that then starts to give us some kind of levels of incidence of how frequently we're seeing safety events. And with tildrakizumab, we're not seeing any real degree of frequency at all with serious infections, malignancies, or any major problems at all. And that can be compared against placebo as well, and indeed etanercept. And of course, etanercept has often had this sphere of a cloak around it that this is a super safe anti-TNF drug. And in these studies, in direct comparisons to etanercept, there were no additional safety signals with IL-23 and tildrakizumab. For gazelkumab, through to 2 and 3 years, so this is then pooling the data. Again, With biologics, we see infections. We see that with all biologics, but it's whether the rate is actually elevated above what we would expect. And actually, by and large, for IL-23s, we're not really seeing any consistent signal or any specific safety events of interest, which is very reassuring. And then finally, risankizumab, obviously the safety data at this stage is a little shorter, but again, was hugely reassuring. One point, I knew the screen would go wrong at some point. One point about risankizumab that is of interest in one of the studies, the fourth study on risankizumab, 31 patients were allowed to go into that study who'd had a test for tuberculosis and were shown to have latent tuberculosis. They did not receive prophylactic treatment, and none of them have reactivated in terms of getting active TB. Now, this is clearly very different to anti-TNFs, and it hasn't necessarily been tested in the IL-17s, but immunologically, we think, again, this is a possible advantage of 17s, a possible advantage of 23s, and has been tested in that RISA program. Of course, you should follow the label for all of the IL-23s, which includes screening for TB, but it's just an interesting point to make. And there has been one published study very recently in The Lancet. Professor Reich was first author, and this was a phase 3 randomized double-blind study comparing, for the first time, an IL-23 against an IL-17. You can see the study design was very simple, over 500 patients in each arm, and the primary endpoint of this study was at week 48. And what it showed was that guselkumab was superior to secukinumab at that time point for that analysis. And so a key study, because we've seen studies before against adalimumab, we've seen studies before against ustekinumab, for the first time we're seeing a 23 go head-to-head against a 17. Again, very good safety within the ECLIPSE study. There were some signals that one might expect with 17s, for example. Kristian's mentioned this already, but this is just for your reference. If you're very interested then in some of the basic science that may have been done to couple with that clinical study ECLIPSE, then it's well worth attending this session in Hall 10 at 9:15, 12th of October. And I think something that we will be keen to discuss, and you may have questions on, is how will IL-23s perform in the real world? Obviously, there's starting to be a little bit of emerging data for guselkumab, but what we want to see is data over 1, 2, 3 to 5 years to demonstrate how these drugs perform outside of a clinical trial setting and how they perform against all the other classes. And I think that's an interesting discussion that potentially we could have later on. So hopefully, I've tried to focus on the IL-23 data. Hopefully I've shown you that by and large the IL-23s are achieving high levels of efficacy. I think it's fair to say they're higher for guselkumab and risankizumab. They've not been compared head-to-head, any of these three drugs, but when you look at the raw data, it does seem to be better for those latter two. But what is common to all of them is a good continuation of response. The withdrawal arm of these studies is absolutely fascinating because that's starting to allow us to explore potentially different guided types of treatment. We need more data to know exactly how to do that, but this is scientifically fascinating as well. The vast majority of patients are achieving great outcomes, DLQI 0 or 1. The safety is extremely reassuring, and as Kristian said, when we think about IL-23 as a class, we don't see things like a candida signal. We're reassured around TB, but you should still test for it. And these drugs are being trialled in inflammatory bowel disease, suggesting that they're going to have a positive benefit on that particular disease. And then you've seen the ECLIPSE data, the primary endpoint of which at week 48 demonstrated superiority for guselkumab over secukinumab. And with that, I'd like to thank you for your attention.
Richard, thank you very much. And the questions are actually pouring in. So use this if you have more questions. I already here have like 12, 13. So we'll definitely have a good discussion at the end. This was a fantastic overview about the clinical trial data. Absolutely clear, absolutely precise. I really thank you for this. Brian, it is your task now to take us even one step further. The different disease domains, the comorbidity, all these problems we have in the clinic, and that are not really tested in clinical trials. So what do you make out of 23 inhibitors with regard to these special manifestations, please?
Thank you, Kristian. Thanks, everybody, for staying. These are my disclosures. So we're going to cover difficult to treat areas. You've seen the wow efficacy of IL-23 P19 inhibitors. Just recap, PASI of 20, all of these patients had. And PASI 90 means a PASI of 2 or less. And if you do psoriasis and you do PASI, you realize how wonderfully effective this is. But what about the other difficult to treat areas? Scalps, fingernails. We're going to show you some data on this as well as a palmoplantar pustulosis. Psoriatic arthritis is very important. 30% of our patients will have this, anything up to 40% more severe disease. How do IL-23 P19s? What's the early data? Look at this. Obesity is a big problem in psoriasis and has multiple effects. How is that going to be? Is this going to be less effective in people who are overweight? We'll talk about cardiovascular disease and how we should be screening for this, as well as looking about psychological disorders, because we need a holistic view of this. This isn't just a skin disease. And we'll also touch on other diseases that are commonly or more overrepresented in psoriasis, as Kristian said, such as inflammatory bowel disease. So difficult to treat areas, about 45-50% of our patients will have scalp. And as you know, if you have people with resistant recalcitrant scalp psoriasis, it's miserable, with itching, bleeding, and manifesting as what people can use in terms of wearing clothes, etc. Genital psoriasis is an important area that's been under-researched in the past. And how do these drugs perform this? A quarter of our patients will have nail disease, rising to 50% of those patients with psoriatic arthritis. And we all have patients who've got difficult to treat palms of their hands and soles of their feet. And yet despite this, these patients get a high DLQI, even though overall their psoriasis may not be regarded as severe. And you're familiar with what scalp psoriasis looks like, and soles of the feet as well. Fingernail disease causes significant issues in those patients that have it, and a nice case of palmoplantar pustular psoriasis as well. So if we look at guselkumab, and this comes from the Voyage 1 and 2 studies, this is a sub-analysis looking at those patients who had hand and feet involvement, and they were using the HFPGA 0 and 1, and looking for a true great improvement from baseline at week 16 to week 24, and this is compared to adalimumab, which really would be, is a very effective drug, as you know. And guselkumab, the primary endpoint of week 16, improves hands and feet psoriasis better than adalimumab, and the same with fingernails. So you get an FPGA of 0.1, so clear or almost clear fingernails in 24 weeks is the better endpoint because nails are slower to respond. 64% of clear or nearly clear nails when treated with guselkumab compared to those treated with adalimumab. So clear evidence that guselkumab works in nail psoriasis as well as difficult to treat areas like the hands and feet. Similarly in the scalp, and I think scalp, as I said, is more tricky, 81% achieving a greater than 2 grade improvement on a scalp PGA score compared to adalimumab, 85% at week 24. So really, again, high efficacy of IL-23 P19 inhibition in a difficult to treat site. Palmoplantar pustulosis. We really have a lack of evidence and a lack of data helping us with these patients. And this is a randomized controlled trial against placebo of guselkumab. And if you focus on the slide on the left, it's a mean log score change, was statistically significant. This is the primary endpoint of week 16 for palmoplantar pustulosis, showing that guselkumab is better than placebo and has got a high efficacy rate, and that this is continued out to week 52 in those patients who respond. So even in palmoplantar pustulosis, we're seeing high efficacy, but also the durability of response that we're expecting in chronic plaque psoriasis with IL-23 P19 inhibition. So what about comorbidities? Well, IL-23, as Kristian talked about the immunology in great detail, as well as being important in the skin, plays a key role in the joints as well, and also in inflammatory bowel disease. And as this master cytokine, possibly, when we look at this simplistically, in lowering IL-17 levels to normal, and maybe not to below normal in most of our patients. So you're well aware of psoriatic arthritis. As we said, anything up to 48% of patients. There's synovitis, the swelling of the joints, enthesitis, the swelling of the tendons where the tendon inserts into the bone, and spondylitis. The more severe psoriasis, it correlates with that you're more likely to get psoriatic arthritis, but a lot of people with psoriatic arthritis have milder skin disease. The big thing for us as dermatologists is that up to 60% of our patients are undiagnosed. We did a study 6 years ago in our clinic in Dublin, and 29% of my patients, when examined by rheumatologists, had undiagnosed psoriatic arthritis. I think we're getting better. But early diagnosis and effective treatment is really important in psoriatic arthritis to stop functional loss, to stop progressive joint damage leading to functional loss, particularly in the small joints of the hands. This is a study that was done by Oliver Fitzgerald and myself in St. Vincent some years ago. But when you see a patient with psoriasis, up to 2/3 of these, or up to 3/4 of them, will get psoriasis between 1 and 11 years, and 1/3 over 11 years after they first get the skin. So it's obvious if they walk in and they've got swollen joints and bad skin. Our job as dermatologists is to detect these people as we go along this road, from diagnosis of psoriasis to those developing psoriatic arthritis. So how do we go about this? Well, these are the CASPAR criteria that are useful for classifying people into clinical trials with psoriasis, but less so for diagnosis. And the top one is the problem that causes, or is the issue that causes problems for dermatologists, is a diagnosis of inflammatory arthritis. Current psoriasis or family history psoriasis gets a score. Nail psoriasis, because 50% of patients with psoriatic arthritis have nail disease, and X-ray changes are the last one on the list. But this is useful for classifying it. But we are the people who see people with early psoriatic arthritis first, and I think it is our responsibility for treating people holistically to diagnose this as soon as is possible. Whether we should be managing this on our own without the rheumatologist is a great debate. My personal view is not, but there are a lot of people in the room where access to rheumatology services are less available. And we certainly, with people who have known diagnosis of psoriatic arthritis, should be able to help in the management of these, particularly with TNF inhibitors and the newer IL-17s, and in time IL-23, P19 inhibitors, because they're not licensed for this yet. The diagnosis can be difficult, and questionnaires have been developed to help us, and we'll touch on that in a second. But we hope over time the clinical cohorts where people have been studied to pick out the clinical features that predict psoriatic arthritis, and together with biomarkers, hopefully we won't be missing these people with psoriatic arthritis in the future, and we'll be finding them earlier, and we'll have algorithms to do this. Do you use the PES score? Do most of you use the PES score? Certainly in the UK and Ireland we do, and this is a useful scoring tool for screening people for psoriatic arthritis. It's also useful in the setting of people who've developed joint pain, because we always ask them, have you got joint pain? But the issue, as you can see in the left-hand corner, is the sensitivity is 0.94. So it's overly sensitive. So we pick up a lot of things that aren't necessarily psoriatic arthritis, and it is less good at axial disease. So we always add in a question, do you get morning stiffness in the back? Back pain, particularly in morning time, can also be a useful discriminator for psoriatic arthritis. So how do IL-23 P19 inhibitors do? You looked at this and you see that it's week 24, and the HCR20 is really what we used to have as PASI 75. This is the rheumatologist's equivalent. And this is compared to placebo. We can see 58% of patients hit ACR20 at week 24, and 30% of ACR50. So that's a 50% improvement in inflammatory joint disease and inflammatory joint count, coupled with a marker of inflammation. These are comparable to TNF figures, as Kristian showed you. We should be careful interpreting because they're not head-to-head, but they are comparable. When I took this photograph over 20 years ago, I was working on PASIs, and I was trying to calculate this man's PASI in terms of area. And of course, I missed the obvious thing in this photograph is that this man is obese. And since then, there's been a lot of work done on how does obesity influence psoriasis. And your fat acts as a pro-inflammatory organ. Old friends like TNF-alpha are produced by fat, particularly central adiposity. Insulin is pro-inflammatory, and insulin resistance is a big part of our patients who are overweight with psoriasis. And psoriasis, obesity, and metabolic syndrome is a two-way street. So patients with psoriasis are more likely to be obese. We know that as you gain weight, we know this from the Nurses' Health 2 study, that you're more likely to develop psoriasis. We also know that metabolic syndrome, which is the really damaging part of obesity for patients' long-term cardiovascular health, is overrepresented. 30% in this study. In our patients in Dublin, 40% have got metabolic syndrome. And we also know that patients with obesity are less likely to respond to TNF-alpha inhibitors and also to Stelara. That's why Stelara has the different dosing regimen, less than 100 kilos, and another higher dose at 90 milligrams for those over 100 kilos. Because we recognize that patients who are BMI is over 30 tend to do less well with biologics. If you look in your clinic, and we published this study some years ago, that 31% of our patients, as I say, are obese, but those on systemic treatment, 40% have a BMI over 30. Similarly, if you look at fasting insulin or insulin resistance, it correlates closely with patient severity as measured by PASI. So the more insulin resistant you are, the more central adiposity you have, the more severe your skin disease is going to be. So why is this important to us as dermatologists? Well, one, it makes psoriasis worse. Two, it makes expensive treatments like biologics less effective. But the third thing is it increases these patients' risk of getting cardiovascular disease. And those patients who are obese have higher framing risk scores, which doesn't take into account obesity, than those who are lean. And we know that psoriasis is associated with myocardial infarction, particularly those at younger age. And this is the classic Gelfand study. But even up to the age of 60, there's a 30% increased risk of cardiovascular and myocardial infarction in patients with severe psoriasis compared to the background population. And this is lesser for mild psoriasis. And we believe that obesity is one of the key factors that's driving this. Gelfand's study has since been replicated in numerous populations. And it's estimated that patients with severe psoriasis lose between 4 and 5 years of life because of early cardiovascular and cerebrovascular death. So Richard presented the data from the ECLIPSE study, and this gives you a nice example. The average weight was 89 kilos, and 42 to 44% of patients had BMIs over 30. This is our challenge as dermatologists. But the good news with gazelkamab in this study is that those patients achieving PASI 90 and those patients achieving PASI 100 was not influenced by weight. So we have seen this with TNF, we've seen this with IL-23, but we don't see this with IL-23p19 as seen with this trial with gazelkamab, and there are similar data available for risankizumab. So again, we don't have to worry as much about treatment response in those patients who carry an awful lot of weight. Similarly, again, this consistent response that we see out to 156 weeks, 3 years of this high IgA of 0 or 1 is clear or nearly clear in people with PASIs of 20, and the duration of response is not influenced by weight either. I'm going to briefly touch on psychological comorbidity because this is something I've got an interest in. 80% of your patients will tell you that when they're under more stress, their psoriasis gets worse. And we know from quality of life data and anxiety and depression data that psoriasis itself causes anxiety and depression. More than 50, odds ratio up to 50%. If you translate that into numbers, 20% of your patients that attend you with severe psoriasis will have clinical depression. 10% of these patients have contemplated suicide. In our patients in Ireland, but I suspect this is similar, maybe more across Northern Europe and Southern Europe, alcohol plays a significant role in this. 30% of our patients misuse alcohol, and this unsurprisingly is associated with higher levels of anxiety and depression. But if you're worried and if you're anxious, it actually limits how well your treatment works in a study that was done with PUVA. And alexithymia, which was reported as part of the EPIDEPSO study, alexithymia is the inability to express emotions or read emotions in other people, is again closely linked to alcohol misuse, is overrepresented in patients with severe psoriasis, but when you treat the psoriasis, this seems to improve. And we think that alcohol, depression, anxiety fit in this rather simplistic but nice diagram. Alcohol excess makes psoriasis worse. Does psoriasis make people drink more? Do you go to the pub because you don't socialize, because you don't go out on dates, because you don't go to the gymnasium? We know that psoriasis, depression, anxiety are overrepresented in this population, but we know, everybody knows that alcohol excess contributes to anxiety and depression. And then if we're talking about increased cardiovascular disease, 4 to 5 years early death with cardiovascular disease and severe psoriasis, of course, depression is an independent risk factor for cardiovascular disease, as is excessive alcohol use. So one of the things I would suggest to you is we need to screen in our patients for psychological comorbidities, and in certainly Northern Europe, including Ireland, we need to look for alcohol excess because it plays a key role in this severe disease. Various interventions have been done in trying to reduce alcohol intake and trying to reduce stress. This is an older study from Manchester showing that if you do things like cognitive behavioral therapy, mindfulness-based therapies, we now have randomized control evidence for this, that you can reduce patients' anxiety and depression, and there's a cognitive behavioral intervention with alcohol which can reduce alcohol use. But interesting in this study, it also improved their psoriasis. So that bi-directional approach, stress makes psoriasis worse, psoriasis gives stress, at least in this study, suggested that you may be able to help the skin disease by helping stress. This is again data from Voyage 1 and 2, looking at DLQI in 0 and 1 in those patients with the better skin clearance, less likely to DLQI 0, 1. So already reducing, improving quality of life and influencing psychological comorbidity by really high efficacy clearance. But also, as Kristian showed earlier, if you measure anxiety and depression scores in patients, and you treat them with gazelkamab compared to adalimumab, you see that, certainly compared to placebo, successful treatment of the skin results in lowering depression levels and lowering anxiety levels, as clearly seen here. And gazelkamab does this better than adalimumab, as you may expect, because it's clearing the skin in a better way. So skin clearance is key to tackling anxiety and depression, but not to everybody, and there are other methods that have got a level of evidence that you should think about. Finally, we'll talk about inflammatory bowel disease. So Crohn's disease, your relative risk is about 2.5 of developing Crohn's disease if you've got psoriasis, and slightly less than 2 for ulcerative colitis. And we know there are genetic factors involved in this, and that these are systemic inflammatory diseases. And we know about the targets for IL-12 and IL-23, plus ustekinumab, which is licensed for the treatment of Crohn's disease and ulcerative colitis. And we know that there are drugs in blue, the blue box, risankizumab, brazikumab, mirikizumab, and gazelkamab, that are undergoing trials for targeting IL-12, 23p19 in inflammatory bowel disease. PTG200 is an oral drug that again may target IL-23 receptor, and you're aware of how JAK inhibitors work further downstream. And again, these are in trial for Crohn's disease, but they are not licensed at this stage, apart from ustekinumab. So if you look at the data on ustekinumab, and these patients need higher doses. The licensed dose is 90 milligrams every 8 weeks after an IV loading dose, because Crohn's is probably more difficult to treat than psoriasis. And these patients are smaller, they're 70 kilos. Nonetheless, you can see compared to placebo, and you can see across a dose effect, that both doses of ustekinumab or Stelara are highly effective in inducing remission in Crohn's disease, improving clinical response, and most importantly in Crohn's disease, reducing the need for corticosteroids. There is inhibition of risankizumab. Again, this is phase 2 data. IL-23 P19s are not licensed for Crohn's disease yet, but you're seeing similar responses again after IV loading doses compared to placebo and at a higher dose of risankizumab that is licensed for psoriasis. So in summary, patients with psoriasis we know are at higher risk of developing comorbidities. The big ones are psoriatic arthritis, obesity, early cardiovascular death, and psychological disorders. They're also at high risk of inflammatory bowel disease. I hope the data I've presented would suggest to you that IL-23 is at the center of the pathogenesis we know in psoriasis, but also psoriatic arthritis, and also inflammatory bowel disease. And we also know by using these drugs that we can improve psychological comorbidities, and that obesity, while it's maybe playing a massive role in terms of their cardiovascular health, doesn't influence outcomes with IL-23 P19 inhibitors, either guselkumab or risankizumab. So we think this is why, in the jungle of cytokines, IL-23 as it is now presents a highly attractive target, not just for managing the skin disease, but for managing a lot of the associated comorbidities as well. Thank you very much.
So thank you very much. I hope you already have a pretty good overview. Can we make a deal? You know that we live in a world where deal making is key, right? So let's make a deal. I look at my watch. Let's have a good discussion for 10 to 15 minutes, okay? You have sent in great questions. We will pick the 7-8 questions that I feel are most important. We'll have a good discussion and then we terminate a little bit prematurely. Is that okay? Yeah? Good. So, Richard, the first question, and the obvious one. You walked us through the clinical trial data for tildrakizumab, guselkumab, risankizumab. There are at least 4 or 5 questions here. Are there differences between the clinical data? And if yes, how can you explain that 3 antibodies that have the same target show differences in the response? Please.
Well, I think the first component of the explanation is if we think about other drug classes where there's multiple drugs within a class, the TNF drugs, for example, behave quite differently, the IL-17s. There are differences within IL-17s as well. So I think there's no doubt that the tildrakizumab primary endpoint was too soon for that drug, but even allowing for that, it doesn't seem to be hitting the same levels of efficacy that guselkumab and risankizumab do. So I think we have to think about pharmacology and also potentially pharmacodynamic factors. By that I mean, how potently do these drugs inhibit the actual target?
Affinity?
Yeah, and there may be differences within that could explain this. And I think that there is an element that we don't currently fully understand either, just being completely open about it.
And there is some pharmacokinetic data suggesting that guselkumab and risankizumab may have a higher affinity for target, but whether that fully explains the clinical outcomes or not, I think is still in doubt.
I mean, you hear us. In theory, the affinity could be different. Affinity measures with what strength does the antibody bind its target. A second difference could be pharmacology, like half-life. Guselkumab 18 days, risankizumab 28 days. That may explain, for example, the differences in the injection interval. But let's not forget that also these antibodies could bind to different epitopes on the P19 molecule, and there could be differences in the functional relevance of the epitopes that the antibodies bind, right? You can call this potency. So there's a number of explanations where antibodies having the same target could be differently. Antibodies could have a different immunogenicity. There are 2 questions here. Do we already know the immunogenicity of drugs like tildrakizumab, guselkumab, risankizumab? The data that I have in my mind is low immunogenicity, if any, clinically relevant for tildrakizumab and guselkumab. And risankizumab, again, if you go to the prescription information, they report anti-drug antibody formation in 10-20%, but with no effect on the clinical response. So my current take is there is no evidence for a clinically relevant immunogenicity, but there could be differences between drugs, right? And we talked earlier about the immunogenicity of adalimumab that seems to be higher than we thought and probably contributes to the loss of response that we see. Yeah? Brian, a clinical question for you, and again, there are at least 3-4 questions around this. You talked about the comorbidity obesity, and we know that weight will impact the clinical response that we see. Can you inform us again on how much does weight influence the response to the 23 inhibitors, the 17 inhibitors? Are there drugs that you would prefer in obese patients?
We've known for a long time that TNF inhibitors, that obesity reduces response and reduces duration of response. It was clear in the IL-23, so in the ustekinumab trials, that when you got to 100 kilograms that there was a drop-off in response. And I think in real life we feel that it's actually at 90. I think the guselkumab data and the risankizumab data it doesn't matter. That's how effective these are. That even though they're going into larger people and they're not weight-based dosing, we're still getting that really dramatic effect. So obesity is there, but in IL-23 P19s, it doesn't seem to be influencing outcome.
Richard, comment? I remember in the old days when a patient was weighing more than 90 kilograms, we were already afraid that adalimumab would, for example, not show the responses that we see in lighter patients. Stelara tries to sneak around this with a 45 milligram, with 90 milligram. I need 90 milligram in the majority of my patients, and Richard, you talked about this in some patients. I would like to give it every 8 weeks, and you showed the breathing of ustekinumab if given to the labeled dose. We don't seem to see this impact of weight with the 23 inhibitors. Would you agree? Would you call it a therapeutic robustness? Is it just due to the fact that 23 is a better target, or do they block 23 more?
I think there was some learnings from, for example, Janssen, who developed ustekinumab and then understood some of the issues around that. I think when they came to target more specifically IL-23, they were very conscious and in effect very clever in ensuring that they were covering a broader weight breadth. And I think the same is true of risankizumab. So I think there is that robustness of response. But I think there are elements that we still, as Brian was alluding to, fat tissue is very immunologically active as well. So I think it goes beyond just simple pharmacology here. Again, we need to understand this immunological relationship to being obese as well.
I would say, well, first of all, we do have drugs that are given on a weight-based doses that can help, like good old infliximab. Let's not forget this. And then I think we see a tendency that those drugs that give us this very high level of response, 17 inhibitors, 23 inhibitors, they seem to be impacted less in their response in patients with high weight. So I would prefer, if you ask me, I would prefer a drug where I know I have a very strong, very high level of response. Would you agree?
Yeah, I would agree.
Yeah. Then there's one question that I want to take myself. This goes back to comparing 23 with 17 inhibitors. And Richard, you presented Eclipse, and for obvious reasons, there was a week 48 endpoint trying to look into the, let's say, therapeutic longevity, and guselkumab was superior to secukinumab. Some of you know that there is now a second study called XORA-R, right? Are you aware of this? Where ixekizumab is compared to guselkumab. And in contrast to Eclipse, this study looks into the very early endpoints. So week 12, week 8, week 6, week 4. The main readout is PASI 100. And Richard, what do you expect to see?
Well, as the IL-17s are extremely rapidly acting drugs, it wouldn't come as a surprise, Kristian, if they were superior at those very early time points.
You remember when Richard once showed you these lines, and you saw that there was a certain trend. It was not analyzed with statistics, but there was a certain trend that even with secu, that you seem to see a little bit an earlier onset of response. And actually, if you think back what I tried to explain to you on the pathophysiology, with IL-17 being this effector cytokine that directly activates the keratinocyte and induces the psoriatic phenotype, I think it is kind of understandable that blocking 17 is probably the best thing you can do if you want a very fast onset of response.
But I think it's still fair to say the IL-23 P90s are fast.
They are fast.
And the separation, between in the risankizumab data between that and adalimumab and in Voyager 1 and 2 relatively early when you look at those secondary endpoints. So it's still quick.
I give you 3 numbers, okay? I give you 3 numbers. Are you ready? If you take the PASI 75 response at week 4, which is probably a fair measure for onset of response, you can expect to see with guselkumab, risankizumab 20-30% at week 4. That's fast. But with IXTA, you can expect to see 50%, with brodalumab 60%. And if you listen to the bimekizumab data today, that may even be higher. So the wedding drug, the patient that comes and says, I have a wedding in 6 weeks, what can I do? I'm positive. When it really, it's a small subpopulation in my patients. The majority want the stable long-term response. But if you are looking for this fast onset of response, then these drugs, they give you a difference. Yeah. There is a little bit of a strange question here, Brian. I thought I would give this to you.
Thank you very much,
Thank you. Marijuana, cannabis. It is talked about a lot. Does this relax you? I personally have never tried, of course.
No, I haven't even inhaled.
Now this never inhaled. Now science, and it is actually available as a pain drug for severe cancer patients,
yes.
And it's doing a lot of good things in these patients with otherwise untreatable chronic pain syndromes. Are you aware of any study where marijuana, cannabis has been tried in patients with psoriasis? It's a real question here.
I'm not aware of any study, either controlled or uncontrolled, or even case reports in the literature. I'm happy to be corrected. The CBD oil is available in some countries in Europe in extreme circumstances for various indications, including pain. But I'm not aware of it being good for psoriasis. Richard?
I think the other thing, I couldn't immediately recall any data on it, but I think the other thing that would cause concern would be, of course, psoriasis is associated with anxiety, depression, everything else, and so the mental health issues that come with that would be potential.
And also, cigarette smoking makes psoriasis worse, and cannabis comes with tobacco.
I'm not completely sure where this
I think at the moment we're saying we'd stick to a 23 or a 17 over cannabis.
Let's stick with stuff we think we know works.
Now, I do not exactly know where this question is coming from. My answer would be, now taking it back to science. If we believe in the concept that the inflammation drives this, and there is now study with infliximab in recalcitrant depression, so be aware that more and more of our psychiatric conditions seem to be initiated by cytokines. We all know this. When you get a flu, and I tend to say not only if you're a male on the second day, you think you're going to die, right? And you can induce this in animal models, sickness behavior. What is the most important side effect of interferon? It's depression. So cytokines change the behavior. So why should I let them smoke ganja if I could treat the cytokine, and by doing so, take away the reason for the depression? So I think it makes more sense to stick to the anti-inflammatory treatments. And this brings me to another question that is asked here. You did not talk about the potential protective effect of anti-inflammatory treatment on cardiovascular problems. Are you aware of any data evidence there, Brian and Richard?
Well, there is well-established data of TNF inhibition reducing cardiovascular mortality in rheumatoid arthritis. That's well-established across several large meta-analyses. So anti-inflammatory treatment, this concept that systemic inflammation accelerates cardiovascular disease, is well established in RA. There's some preliminary data in psoriasis suggesting that treatment with TNF or methotrexate, so just systemic anti-inflammatory treatment, can reduce cardiovascular disease compared to those people treated with topical alone. We won't get randomized control data on this because these are too long and too far out, I suppose. So I think instinctively, RA and psoriasis, particularly in psoriatic arthritis, I think there probably is a benefit. But I think the other things that we need to tackle are the cigarette smoking, in northern Europe, alcohol excess, the obesity, and measuring hypertension lipids and controlling those as well.
Okay, so I promise to you, so 2 more questions. And if you have a burning question, most ask their questions anonymously. I don't know if this is because of shyness. We don't eat anybody here. But if you are also invited to go to the microphone if you have a burning question. 2 more questions. Richard, to you. Which would be your first biologic in a patient with psoriasis? So how would you make your decision when it comes to the first use of a biologic?
So, I mean, inevitably, you've got to take a detailed history from the patient. We've discussed comorbidities and the relevance of that. We've discussed what the patient may want. But all other things being even, If it was just pure plaque psoriasis, I would probably opt for an IL-23 antagonist.
And I agree. However, let's not forget, and Brian, you showed this nail comparison from a study where guselkumab was so much better in treating plaques than adalimumab. When it came to nails, adalimumab was still very strong, and it took guselkumab 24 weeks to get there. So is there an adalimumab patient still for you?
Yes, there is, I think. The psoriatic arthritis, because we have phase 2 data for IL-23 P90s, but we don't have phase 3 in a license yet. Axial disease, particularly within psoriatic arthritis, because we don't have the things that work and that have been shown to work are TNF and IL-17. So I think...
So moderate psoriasis, but significant arthritis and nail disease.
Yes.
Maybe a candidate for adalimumab.
Yeah.
What if there is a lot of skin and arthritis? What would you pick then as your first biologic?
As we are now, following license, I would pick anti-IL-17A.
Yeah. So you see, there is no one size fits all, and this is just a top line overview. If I'm allowed, I would like to take the last question, and this is an interesting one. Is there any evidence that patients with psoriasis have subclinical PSA? And could we think of a therapy that we might call disease interception? So you do a treatment in order to prevent the first manifestation of psoriatic arthritis. The answer is I don't know. But I have seen yesterday a study in a small number of patients, 20 patients, where they analyzed the joints by MRI, and in 80% of their severe psoriasis patients, they could identify subclinical PSA. Guess what? They treated them with the IL-17 inhibitor, and they could see a great reduction within 24 weeks of the subclinical inflammation. Now, I don't know if this gives us the answer, but I think it opens the door to the concept that with some of our targeted therapies, we may be able to prevent comorbidity. And I think this is an interesting concept. I would like to finish by encouraging us all to be more ambitious, to use the therapeutic armamentarium that we have. I think there is no excuse in 2019 to not get the psoriasis patient under control. We do have anti-TNFs, we have the 17 inhibitors. I hope we could contribute a little bit with the help of Richard Ward and Brian Kirby to introduce to you the latest class, the 23 inhibitors. If you make use of our whole therapeutic armamentarium, the great news is I at least get almost all my patients to a level where they say, I'm no longer bothered by my disease. And I think this is a fantastic situation, and it really motivates me to stand up every morning and say, I go to my office and I treat my patients. Thank you very much for your attention.